Hello, I am Dr. R K Mani, Group CEO of Nayati Group of Hospitals, Nayati Medicity Mathura, Nayati Medicity Amritsar, and Chairman, Pulmonology, Critical Care and Sleep Medicine. In Mathura, there was a 2-day roundtable meeting on end-of-life care. The issue in India has been under debate for close to 2 decades, but not much progress has been made. This is because of great confusion in terminologies relating to end-of-life care, and the principles and policies are yet to develop. Against this background, there was a meeting consisting of multi-speciality and multi-professional participants. The proceedings were designed in a way to generate brainstorming on various contentious and ambiguous issues in our midst. There were doctors, social workers, writers, religious workers, and sociologists and thinkers participating in the event. For an issue of such public importance as end-of-life care, a broad consensus, participation, and capacity building is required. And to this end, the agenda consisted of the importance of certain essentials which need further exploration, which is emphasis on the needs of dying persons or terminally ill patients, the possible burdens that may be imposed upon such persons, and what we as a society and we as professionals can contribute towards its improvement in terms of debate and discussion and formulation of policy, and finally construct a legislation. For this purpose, the professional group called ELICIT, which has taken upon itself the advocacy for changes or reform in EOLC, came together with the Citizens Forum called Candid. The meeting concluded with a declaration called the Mathura Declaration, enunciating the call for action to the public, to professionals, and to the government for focus on end-of-life issues. The issues are that while we know when to apply interventions, there needs to be medical, ethical, and legal guidance to set limits for such treatments, when not to apply and when to remove if applied and found to be futile. There are many contentious issues that are linked to these questions. When do we recognize that interventions are with reasonable degree of certainty not useful or become burdensome? Who decides, and who would monitor, and how we can regulate this process are the questions that were explored in this meeting. Much of this has been confused with the term euthanasia, which has stopped progress and evolution in this field in the last 2 decades or so. We have misunderstood, going by media discourse, the true meaning of euthanasia. It is not a broad term wherein any form of treatment refusal is defined as euthanasia. It is very specific, which is actual killing of the patient, intending to do an act of mercy by a medical professional. Now this is a very narrow and specific definition and applicable in a legalized way only in a very few countries of the world. However, the broader term end of life care, which includes several ways of reasonable treatment limitation, such as the do not resuscitate directive or decision, withholding of interventional treatment, and withdrawal of interventional treatment. These terms are completely distinct and delinked from the term euthanasia. It is also germane to note that these decisions, DNR, withholding and withdrawal, has been in everyday practice in the Western world for the last 30 years. 75 to 90% of those dying in the ICUs of Europe and America do so with a treatment limiting decision. Contrast this with India, where hardly any have this well documented decision making. The decision making in a standardized way comes with a frequent dialogue between the treating team and the patient if capable, or with the family if the patient is not competent to do so. And through this process of dialogue, a shared decision making is arrived at. The laws in many parts of the world enable this process and put it within a well-defined, clear framework so that doctors can act ethically and effectively in the end-of-life phase for the patient. We must also work towards creating a contemporary legal framework in our country. This process is on. The Ministry of Health and Family Welfare last year called for response to its draft bill on so-called passive euthanasia. Passive euthanasia again is a misnomer and probably an outdated term for end-of-life care limitation of interventional treatment. We should abandon confusing terms and take to the contemporary terminology and definitions. Since this process requires advocacy at several levels, at professional and at the citizens level, there was a group of professionals termed ELICIT who took the first steps in this direction. ELICIT is acronym for End of Life in India Task Force, which brought together three medical associations: Indian Society of Critical Care Medicine, Indian Association of Palliative Care, and Indian Academy of Neurologists. To this has added now a citizens forum called CANDID, Citizens Action for Dying in Dignity, or Citizens Action Needing Dignity in Death.